I think there are two main factors in the design of our programs. One is that, number one is that we're working with a post-conflict population. And that is a very important thing to consider when you're implementing a program in that community. The people who we're trying to train, the doctors, nurses, and midwives, and so on, they have all, or most of them have experienced some personal trauma. And they carry this burden with them. And they bring it to the workshops with them. It's very different than teaching students at USC or UCLA or any other area. You have to deal with this heavy burden that they carry with them on a daily basis. And we have taken steps to address that. For example, I had a male nurse that came up to me during one of the programs, and he said, "Ms. Tarani, do you know what my job was before I became a nurse?" And I said, "What was your job?" And he said, "My job was to patrol the mountains and locate and kill the Taliban." And I got to thinking about how does this transition work from taking lives to saving lives. So this individual requires some extra attention, some strategies that would help him focus. So, because ultimately we want them to do what we are asking them to do. If we're asking them to use instruments correctly, to follow that protocol, if we can't get them to focus, if we can't get them to realize their own potential, their role of agency, how can they contribute to their community, our programs are not going to have the outcome that we desire. So that's one difference. The other difference is I think our programs are culturally appropriate and culturally sensitive. We know that women in these societies have to deal with a lot of challenges to access health services, to access contraceptives. In societies such as Afghanistan, male-dominated societies, men make all the decisions at all levels, including the permission to use contraceptives. So here if we have a woman who cannot use contraceptives because the husband will not allow it, if we solely focus on women, it would be like trying to haul a large boulder up the mountain on the shoulders of women alone. So any discussion of expansion of family planning to reduce maternal mortality in male-dominated societies must include men. The men have to share the burden of moving this boulder up. And it doesn't take very much to talk to Afghan men or otherwise Muslim men or any man to let them know that what they can do to help their families. In Afghanistan, for the most part, we have excluded men from this process. There's very little activity in trying to involve ordinary Afghan men. This is a partnership. If we want healthy women, we have to get men involved. And I think part of it is because we have followed perhaps a Western model where the women's empowerment and women's independence, and so we don't think about how vital it is for these men to be involved in this process. By bringing men on board, by talking to ordinary Afghan men and looking at them as an asset, as a resource in improving women's lives, not as so much as a villain, but as a contributor, as a partner. I haven't met an Afghan man that did not care about learning how to improve the lives of his wife and his children.